Hello, I am your host Facundo Batista, and together with Richard Young and Lena Afeyan, we have organized this MIT course on COVID-19, SARS-CoV-2, and the pandemic. On behalf of the three of us, thank you very much for joining us today. The purpose of this course is to learn what we know about this virus, the pandemic, from top-class scientists in different areas relevant to this new coronavirus. And who better to teach us about this pandemic than our distinguished speaker today? I have the great honor to introduce you to Dr. Anthony Fauci. Dr. Fauci is a true scientific hero. His public service in the promotion of scientific research long predates this COVID-19 epidemic and has been transformational. Dr. Fauci has been the director of the National Institute of Allergy and Infectious Disease, NIAID, at the NIH since 1994, where he oversees a diverse research portfolio focused on infectious and immunomediated diseases. During his tenure, his leadership has made HIV treatable and potentially a curable disease. And along the way, Dr. Fauci has done more than any other person to increase funding for science. As the longtime chief of NIAID Laboratory of Immunoregulation, Dr. Fauci has made many seminal contributions in basic and clinical research, and he's one of the world leaders most cited biomedical scientists. During this time, Dr. Fauci has advised 6 presidents. He was one of the principal architects of the President Emergency Plan for AIDS Relief, PEPFAR, an HIV treatment program that has saved millions of lives throughout the developing world. Dr. Fauci has been awarded numerous prizes, including the Lasker Award for Public Service and the Presidential Medal for Freedom, which is the highest honor given to a civilian by a US president. Thank you very much for joining us today, Tony. We are incredibly honored to have you here with us, and we are looking very much forward to your talk.
Thank you very much, Facundo. It's a pleasure to be with you, and I want to thank you for giving me the opportunity to be part of this very important course. So let's get started then. As you can see from my title slide, I've chosen the title to be COVID-19, looking at both the public health as well as the scientific challenges. I want to start off by putting it into a much broader perspective. I show the cover of this journal, which my colleagues and I in January, literally just a couple of weeks after the appreciation that we were dealing with a brand new virus that had broken out in China, I wrote this viewpoint and I entitled it, not to be facetious at all, I entitled it Coronavirus Infections More Than Just the Common Cold, to bring out to people who may not fully appreciate it that our experience with coronaviruses goes back decades and decades and decades. And in fact, if you look at the phylogenetic tree of coronaviruses, you see a number of human coronaviruses in red, and many of them are seen in bats and other intermediate hosts. 4 of these, which are highlighted in yellow, are responsible for the common colds, which we get recurrently every winter. About 15 to 30% of all the recurrent common colds that we get, usually during the winter month, are caused by 1 or more of these 4 coronaviruses highlighted in yellow. And then we had another experience as time went by. We saw the first 2 of the pandemic coronaviruses, the original SARS, which we now call coronavirus 1, and MERS, or the Middle East Respiratory Syndrome coronavirus. So let's take a quick look at this. In 2002, the severe acute respiratory syndrome emerged again from China, from the Guangdong province. It was a similar situation of going from a bat to a civet cat, which is often served at festival dinners during festive times in China. It was very clear that that then jumped species to humans. This took place in the Guangdong province of China in 2002. It was first felt to be an atypical form of pneumonia and likely influenza, strikingly similar to the story which we see years later with coronavirus 2. An individual went from Guangdong to Hong Kong, and it was only in Hong Kong when that person stayed at the Metropole Hotel and infected approximately 10 people at that hotel, who got on planes and went to different parts of the world, showing the importance of air travel in the spread of a potential pandemic. And in this case, it actually did turn into a pandemic. Nothing like we would have experienced sometime later, but certainly has the characteristics fulfilling the definition of a pandemic, with 8,000 cases and almost 800 deaths. Its ability to spread efficiently from human to human was not really at a very high level. And in fact, containment strategies, which did not include a vaccine, were things like isolation, quarantine, travel advisories, screening deported airline passengers, and then very, very soon, using purely public health measures, the outbreak died out and essentially disappeared. So we had the first coronavirus pandemic that hit us abruptly, killed a bunch of people, and disappeared. 10 years later, in 2012, we had another emergence of a potentially pandemic. And I say potentially because it never really fulfilled the criteria for a pandemic. It was a novel coronavirus isolated in 2012 in a person in Saudi Arabia, and hence the name Middle East Respiratory Syndrome. It was felt to have gone from a bat to a camel to a human, and then inefficiently, but with a high degree of mortality, it began to infect humans. Note from this slide, there have been about 2,500 cases, over 800 deaths with a high mortality rate. In other words, it has the characteristics of high mortality, but not a very efficient spreader from human to human. This becomes very relevant when we talk about what would happen next. And this is just the confirmed cases of MERS indicating independent introductions into society. Then, going back 8 years from then, when you have the third coronavirus that is not only potential, but reality of a pandemic. Again, with the Chinese identifying a new strain in January, clear-cut relationship to wet markets where bats and other animals are in the proximity of humans, giving us what we call an infringement on the animal-human interface, because many of these animals were forest animals, were brought in and not usually in contact with humans. Well, clearly we had a species jump, and here we then had the third pandemic virus shown in this phylogenetic tree in more proximity with the original SARS coronavirus 1, hence the terminology coronavirus 2. So just to be clear, the disease is COVID-19, standing for Coronavirus Disease 2019, since the first cases were recognized in the last week of December of 2019, although there was likely spread in China weeks before that. And the virus, as I mentioned, is referred to as coronavirus, SARS coronavirus 2. So where are we with that? From a handfuls of cases, 20 plus cases identified in January of 2020 in China, to the explosion of a historic pandemic upon the globe, which the latest counts as of yesterday, almost 32 million cases and just short of 1 million global deaths, with the distribution shown on this slide. Unfortunately for us, the United States is clearly the worst hit country in the world, with 6.8 million cases. And by the time I'm speaking to you today, there will be 200,000 reported deaths. This is yesterday's number. Now, if you look at what I often refer to as the United States being a very large country with a great deal of heterogeneity, not only geographically and demographically and climate and otherwise, but in how this virus struck us. And I'm going to show you in a rapid sequence of slides something called test positivity, namely the percent of tests that you take that are positive, which are always a good indicator of the cases that will follow. So this is March 15th. When you go to April, you see the high concentration in the northeast part of the country. At this point, the New York metropolitan area was accounting for 50% of all of the cases, the hospitalizations and deaths in the country. When you move to May 15th, we see a diminution in the new cases in the metropolitan area. They had already peaked. And the beginning of cases or test positivities in the South, which by the time we got to June, that increased a bit. And then we started to try and open the economy, but we did it in a way that wasn't strictly according to the guidelines that I had a role in putting together for Gateway Phase 1, Phase 2, and Phase 3. And then you could see the hot spot in the country becomes the southern states. And then as we get into August, that continues a bit in Florida and Texas, but we get the middle of the country and some of the Northwest gets involved. And then the heartland of the country in September, as we see on this slide. And then again, we start seeing it in the center of the country with the dark red blots. So what we've had is shifting foci of the outbreak. If you look at the Northeast and look at the dates on the bottom, March through September, peaks up and comes down. As it's coming down, the Midwest comes up, the South peaks and is starting to come down. And now we see the West has gone up and is starting again to come down. Now I'm going to show you some interesting graphs. Looking at the situation in the United States versus the situation in Europe. So if you look at the blue line, Europe peaked a little bit before we did. But after its peak and shut down, they really shut down. And their baseline went way down low, well below 10,000. When you're looking at August through September 21st, namely yesterday, and you read in the newspapers, you see that again, in trying to open up their economy and people going back to schools and the universities, going back to bars and crowding, you're seeing a surge in Europe. But before you focus on that, I want to compare the baselines of the USA in red compared to the blue with Europe. We peaked and then we came down. New York came all the way down. But because of what I showed you in the progression over months in the previous several slides, our baseline never got down below 20,000. And when we tried to reopen the economy, we saw a surge of cases that brought us up to 70,000 cases per day. And now we've plateaued at around 40,000 cases a day, an unacceptably high baseline. So why did we never go down to a good baseline? Well, when you compare by various parameters how Europe shut down, they are in the light lines, the US is in bold. I picked Italy and Spain as representative of the European Union. So when you look at how many people visited parks and outdoor spaces, clearly Italy and Spain shut down more than the USA. When you look at people who went to their workplaces, again, clearly Italy and Spain shut down more than the USA. And finally, when you look at things like going out to grocery stores and pharmacies, Italy and Spain shut down more than USA. That's not the only explanation for why we never got down to a low baseline, but it certainly is something for serious consideration. Okay, let's look on now to transmission, something you by this time and the previous lectures you have are almost certainly very familiar with. Transmission by the respiratory route with close contacts with a variety of sizes of particles. I am sure that aerosol plays some role. I don't know exactly the relative proportion of the role in transmission, but there is indication that particles can stay in the air longer than it takes to just come out of the mouth and drop. Virus is found in various places, infected surfaces, body fluids. Animals can also get infected. The role these play in transmission is unclear and likely minimal. The type of transmission, transmission and the duration accounts for the efficiency of whether a virus is spread. Secondary infections are common among household contacts and closed settings, such as cruise ships, nursing homes, prisons, meatpacking places. We've seen numerous clusters after social gatherings where the risk of transmission goes up, particularly when people don't wear masks. Here's some examples. The famous Skagit County, Washington choir incident, in which a single person in a choir who was symptomatic did not fully appreciate that they might be spreading. 87% of the choir got infected, showing those where they were seated next to that person who was infected. Also, family gatherings, as reported in Chicago, attendees at church functions, as shown in Arkansas, when people congregate together, particularly without masks. I'll get to that in a moment. Also, the CDC just came out with community exposure among symptomatic adults where you likely will get infected: in restaurants, in bars, in gyms, and as I mentioned, in church and religious gatherings, particularly when people do not wear masks. Now, one of the most extraordinary things about this outbreak that you probably have heard from others is the high percentage of people who are infected but without symptoms, who never get symptoms. It's estimated that that is about 40 to 45% of all infections. But importantly, if you model this, it is likely that up to 50% of transmissions come from someone without symptoms transmitting it to an uninfected person, which makes contact tracing in a community setting extremely difficult. Now, getting back to the congregate settings that I mentioned, why we feel very strongly that there are 5 fundamental principles that I and my colleagues talk about to prevent the acquisition and the transmission of SARS coronavirus 2. Universal wearing of masks or cloth face coverings. Maintain physical distance. A 6-foot rule is reasonable. Avoid crowds in congregate settings. Do things outdoors better than indoors if possible, and frequent washing of hands. What about clinical manifestations? We know now it's pretty tight that the incubation median period is about 5 days. The range is about 2 to 14 days. Clinical presentation strongly resembles a flu-like syndrome, as shown by the signs and symptoms on this slide. Of interest, there is this peculiar loss of smell and taste in many people, which precedes the onset of the respiratory symptoms. As I mentioned, 40 to 45% of people have no symptoms. Of those who do, the overwhelming majority have mild to moderate symptoms. About 20% have anywhere from severe to critical. The case fatality rate varies depending upon the severity, anywhere from a few percent to those who are on ventilators, when it goes up to about 20 to 25%. The manifestations of severe disease, the most common being acute respiratory syndrome. But the more we learn about this disease, we morely see the protein manifestations of severe disease, from hyperinflammatory syndromes to cardiac injuries, leading to arrhythmias and cardiomyopathies. Several examples of deaths acutely of people with arrhythmias or cardiomyopathies leading to congestive heart failure. Acute kidney injuries, neurological diseases, a peculiar hypercoagulable state leading to either microthrombi in small vessels or acute stroke from thromboembolic phenomenon, and a multisystem inflammatory syndrome in children. In fact, there are about 800 cases reported worldwide. This is a case from the New England Journal of Medicine of 186 individuals, mean age of 8 years old, where 80% of them required an ICU and 20% required mechanical ventilation. Now, what we're starting to see more and more of, and we're launching studies to see what the extent of this is things that are being called long haulers, people who recover from either moderate disease or even hospitalized patients, but even people who just were sick enough to stay home for a couple of weeks. What they have is lingering symptoms varying from weeks to months and maybe longer. Myalgias, fever, fatigue, shortness of breath that's unexplained, neurological abnormalities, and things that are called brain fog or difficulty concentrating. Some of these have already been reported, but more and more people are accumulating. Another thing that's disturbing is people who recover completely. They clear virus and they feel asymptomatic. A cohort of 100 German patients who recovered from COVID-19, a very high percentage by imaging, such as MRI, revealed some degree of cardiac involvement. The extent to which this becomes symptomatic is unclear. We don't know. But if you have MRI revealing cardiac involvement, 60% with myocardial inflammation, you get concerned about a later, months or maybe years later, of an increase in arrhythmias and cardiomyopathies. We don't know that now. So we want to make sure that we don't say something that has been proven, but this is an interesting finding. In addition, athletes who underwent cardiac MRI following being positive for SARS, about 15% of them had cardiac MRI findings consistent with myocarditis. We need to keep our eye on this. This is an evolving story, and we don't know enough about it to make definitive statements. Okay, let's take a look at who is at increased risk for severe illness. Clearly older adults. You look at the data, there's no doubt about it. This is the data from about 10 days ago, showing from the left to right, the relative proportion of people who are hospitalized per 100,000 population. As you can see, a very low level among young individuals. We're starting to see more and more people from the ages of 30 to 50 who are getting into serious trouble. But clearly it is very highly bent towards those who are 75 years of age or over. However, people of any age with underlying medical conditions, some of which are strongly associated and some of which are moderately associated. Those diseases that are strongly associated with an increased risk are shown here. I want to point out a few that clearly stand out. One of them is obesity. The other is diabetes, as well as chronic obstructive pulmonary disease. Those conditions that are more weakly but still associated with an increased risk are shown here. I point out one or two that are really quite frequent, and that is hypertension and type 1 diabetes, again, and other chronic lung and cardiovascular diseases. Now, one of the things we really need to appreciate is what the relative percentage of people in our population in the United States actually have an underlying condition. It is stunning to see those data where 40% of people have some underlying condition, may not be severe, but have some underlying condition that would fall into the category of what I showed you on the previous slides. About 30% of people can be classified as obese, and over 10% having some form of diabetes. And then you see the rest of the slide with COPD, heart disease, and kidney disease. Another issue that is very difficult to really accept because it's so true, and that is, here again, another disease where you have a disparity of suffering in morbidity and mortality because of racial and ethnic disparities, particularly in this case among African Americans, Latinx, and in some respects, American Indians, Alaska Natives, and Pacific Islanders. Again, the data are striking. If you look at these data from 10 days ago, again, using the parameter as the rate of hospitalization per 100,000 population, take a look at blacks in the upper bar, 349 compared to whites at 75. If you look at deaths, same thing. Look at blacks, 94 deaths per 100,000 compared to whites, 40 deaths per 100,000. Quickly going to diagnostics, I'm sure you've heard about this in prior lectures. There's a couple of major types. The molecular test is the most often used, the PCR, highly sensitive, highly specific, generally costs some money, takes a few days to get a result, and isn't suitable for high throughput. Antigen tests that are coming along are, in fact, more amenable to high throughput. Some of them are less sensitive. They do quicker and cheaper. And then there's antibody tests that are detecting whether or not you were infected. Most recently, the government has purchased 150 million of the Binax Now card test of Abbott, which is an antigen test, 15 minutes, costs about $5. You don't need any special equipment. They're going to be distributing these now to nursing homes, schools, and other areas where you want to do broad screening. Let's talk about therapeutics. The NIH has put together a treatment guidelines panel, which are a group of experts from all over the country who, in fact, are expert in the clinical care of and understanding the pathogenesis of COVID-19. They meet frequently and have developed a living document that's online that you can access through COVID-19 treatment guidelines.nih.gov. And you could look at clinical data that's published as well as data that has just come out, not yet published, is pre-peer review, expert opinion, or what have you, to help clinicians who are confronted with various aspects of the clinical manifestations of COVID-19. These are some of the therapeutics. This was recommended by this guideline panel, two of them, remdesivir and dexamethasone. I'll get to them in a moment. But for the others, there are a number of clinical trials in various stages of development, looking at antivirals, blood-derived products such as convalescent plasma, hyperimmune globulin, monoclonal antibodies, multiple tests looking at outpatients, inpatients, prophylaxis, etc. A lot of activity on monoclonal antibodies. Also immunomodulators like inhibitors of cytokines, interferons, anticoagulants for the hypercoagulable state. Let me just take a couple of seconds to point out to you that good, ethically sound, scientifically sound clinical research can be conducted in the middle of an outbreak, as this study, which was a randomized placebo-controlled trial of over 1,000 patients in the USA, Europe, and Asia, who were hospitalized with lung involvement, who were given a dose of remdesivir, doses. It's an infusion intravenously, but hopefully we'll be able to convert to a more user-friendly approach. But remdesivir resulted in a significant diminution in the time to recovery, and it was unequivocal. The data were very, very clear. It was a moderate diminution, about 32%, but it is now being widely used with good results. The UK did a similar type of study in the sense of a randomized placebo-controlled trial of over 6,000 individuals. Again, those on ventilators, those who required oxygen, and those who did not receive respiratory support. And they had a substantial, significant diminution in 28-day mortality in the treated versus the placebo group. Of note, there was no benefit for those with early disease, and in fact, even a deleterious and negative effect, which really goes along with what we understand about the pathogenesis, that early on, you need to attack the virus and keep the immune system intact, whereas the late disease is often driven by an aberrant inflammatory and immunological response, which goes along with the dexamethasone being good for late disease, but not good and maybe even slightly harmful for early disease. And then finally, there's vaccines. There are two approaches to vaccines: the perfection of novel platform technologies and prototype pathogens. We used this approach in developing vaccines for COVID-19. The first is the perfection of novel platform technologies. A number of them are being used in addition to the standard recombinant proteins. Things like genetic immunizations, mRNA, I'll get to those in a moment, viral vectors, nanoparticles, virus-like particles. The better we get with these novel and even established technologies, the more quickly we can enter into clinical trial and get the answers that we need. Then there's the prototype pathogen approach, which means use previous experience with microbes, in this case, viruses, that form within the same category. And I just gave you a hint of that in my introduction when I spoke about the original SARS, common cold viruses, MERS, because prototype pathogens, you build on prior experiences. And we did. We had experience with many of human coronaviruses. The common cold viruses, I spoke to you about SARS and MERS, and now we're confronted with SARS coronavirus 2. So the basic virology, the animal models, the antigen targets, the platforms, the potential immune correlates, they're not very different when you're dealing with one of a number of prototype pathogens. In this case, it happens to be a coronavirus. And in fact, Barney Graham and Kizzy Corbett from our group at the Vaccine Research Center recently wrote a paper in Nature in which they showed in a step-by-step way how the vaccine approach that we had used for one of the multiple vaccine candidates, namely the mRNA, was enabled by prototype pathogen preparedness. In other words, what we knew about spike proteins, what we knew about the receptor, namely the ACE2 receptor. So that if you look at the timeline of the development of vaccines, and it was a very interesting experience. On January 10th, the virus sequence was released. A few days later, well, that next night, I called my staff into the room I'm sitting in right now, giving this lecture, and said, we better move on the development of a vaccine. This looks like it could be something important. And we did. We started on the development. 65 days later, we went into a phase 1 trial. 132 days, phase 2. And then 198 days later, we started a phase 3 trial in July the 27th. This is the fastest anything has ever gone from sequence into a phase 3 trial. We didn't cut corners for safety. We didn't cut corners for scientific integrity. And then when it came to multiple candidates, we took a strategic approach. It's a paper that I wrote with my colleagues, Larry Corey, John Muscola, and Francis Collins in Science. And we called it a strategic approach because we had a harmonization of protocols where we had common data and safety monitoring board, common primary and secondary endpoints, and common immunological parameters so that you could bridge from one study to another. And these are the studies that are in play. 3 separate platforms that I mentioned: nucleic acid with mRNA, viral vectors, chimp adeno, human adeno, VSV, measles, and protein subunits with and without an adjuvant. There are now 3, and very soon to be 4 of these going into phase 3 trials. And those are the kind of things that I mentioned a slide or 2 ago, how quickly that happened and how the technology and understanding prototype pathogens allowed us to do this so quickly. We proceeded at risk. So people say, what do you mean by at risk? Are you risking safety? Are you risking scientific integrity? No, it's a financial risk. In other words, you invest in things that cost a lot of money before you even have an answer to whether the prior step worked. And a classic example is the production of large-scale amounts of clinical lots, which have been produced and are being produced before you even know that your vaccine works, so that you have hundreds of millions of doses ready to go. If the vaccine works, you've saved many months. If the vaccine doesn't, you lost a lot of money to the tune of hundreds of millions, if not billions of dollars. But it was felt it was worth that investment and that risk financially in order to save time. So I want to take a look at this for a moment. For those of you interested in where the prevention network is going with vaccines, you can just log into coronaviruspreventionnetwork.org, and hopefully some people who might see this would be interested in volunteering for a trial. And you could do that, no obligation, but you could see what's available and at least express your intention of volunteering. I'm going to close with this last slide that we wrote a couple of months ago, David Morans and I. We called it Emerging Pandemic Diseases. How did we get to COVID-19? And it really talks about so many of the things that are associated with emerging and re-emerging infections. Violation of the animal-human interface, the situation that is involved with travel, the ability to go quickly from one place to another. Things like wet markets in China, which get back to the animal-human interface. Things that might even be involved with climate change as we modify where vectors and others go. One of the things that's the bottom line that I've said this now for many, many years, pandemic outbreaks have occurred historically forever before even recorded history. We've had experiencing with them in our own relatively brief lives, and certainly there will be pandemic outbreaks in the future. It's a perpetual challenge, and we need to be perpetually prepared. So thank you very much. Happy to answer any questions if we have time.
Thank you very much, Tony, for an inspirational talk. I mean, the students are really excited. I mean, the inbox has arrived really many, many questions, and we will pose some of you to you right now. I mean, one question comes from Kiwi, and she's asking, as an immunologist, I want to hear your opinion on what do you think about achieving herd immunity for SARS-CoV-2?
Yeah, so herd immunity, as you all know, is when you have a certain percentage of people who are protected, that they would protect those who are unprotected in the sense of either have not been vaccinated or can't get vaccinated and yet have not been infected. We don't know what the number is. Calculations say it's somewhere between 50 and 75%. This is an estimate and not a solid number. We know for measles, which has a 98% effective vaccine, that the herd immunity, when you get below 90 and get into the 80s, you get into some trouble, as we've seen with outbreaks when people stop getting vaccinated. So we're estimating that it's somewhere on the high side, I would say 70, 75%. We're not anywhere near there yet, Facundo. And that's one of the reasons why when people say, well, why don't we just let everybody get infected, and get herd immunity? Well, if already 200,000 people have died, and if you want to just let things go to get herd immunity, you're going to get a lot of suffering and a lot of death. So that really is something, if we get herd immunity, let's get it with the vaccine and not by letting everybody get infected.
Thank you for that. And in a related question Peyton is asking, do you feel that a rapid implementation of public health measures could eliminate COVID-19 in the US at this point?
You know, I think it may not eliminate it, but it certainly can get it down to a very low level, because we know that if you shut down and really shut down, essentially sheltering in place, you can dramatically diminish the infection. The only thing is that whenever you try to reopen up, the virus doesn't disappear, and you can't shut down indefinitely. You will destroy the economy, and it will have negative impact on other health issues where people can't see physicians, can't get screened for cancer, can't get, things that are procedures that are not emergency procedures that all of a sudden become emergency if you don't do them right away. So you really do need a vaccine because you can't stay shut down forever. So the answer to the questioner's question is that you can very well control the virus by very stringent public health measures, but you're not going to eliminate it. You've got to have public health plus a vaccine.
And related to that, Dylan is asking, what is the most likely vaccine development and rollout timeline in the US?
Yeah, you have a good question, because you can certainly know there's a lot of discussion about that is kind of conflicting. So the phase 3s started at the end of July. They range from 30,000 people to 44,000 people to 60,000 people. So you enroll individuals by giving them a prime. 2 of the vaccines, 28 days later is the boost. One of them is 21 days later is the boost. And then you got to wait for people to get infected. So you have to have enough infections. And in one of those trials, the number of infection was 150, 153, and another was a different number, that you can statistically model how many infections you'll need in order to get an answer of a 60% or a 50% efficacy. So it's going to take a while to do that. My projection has been that we'll know whether we have a safe and effective vaccine somewhere around November or December. Is it feasible that it could be October? Yes, Facundo, I think it is feasible. If you got a lot of infections in the sites where the vaccine is being conducted, you might luck out and be able to get an efficacy signal. So it could be October, but I think it's going to be November or December. Now, here's the issue. Everybody's talking about when we're going to roll the vaccine yet. You have to prove it's effective and safe. We haven't done that yet, because even though there's infections, the only people who will know what the data are will be the unblinded statistician in the Data and Safety Monitoring Board. It's not going to be CNN. It's not going to be me. It's not going to be the White House. It's not going to be anybody but the unblinded statistician from the Data and Safety Monitoring Board. And when that person sees that the number of infections have led to a crossing of the point where you say you have efficacy, then they let the company know. The company goes to the FDA, and then it becomes public knowledge. But right now, nobody really knows any data because it's all double-blinded, placebo-controlled.
So Kellen is asking whether, do you expect that COVID-19 will demonstrate a seasonal effect and could substantially worsen the current outbreak in the Northern Hemisphere this winter?
Well, I'll answer the second part of the question first, Facundo, that if you have a simultaneous flu and COVID, you're going to get into trouble, because we know from some early data in March, when we were starting to see some cases, that doubly infected is probably a higher mortality than single infected. So here's what we're going to do to try and prevent that. One, get as many people vaccinated to the flu as you possibly can, and hope that what the Southern Hemisphere experienced in their flu season, which goes from April to the end of August is what we're going to experience. And that is that they wore masks, kept physical distancing, avoided crowds in order to protect against COVID. And what they secondarily did is they had almost a non-existent flu season, because the same things that prevent you from acquiring and transmitting COVID prevent you from acquiring and transmitting flu. So their flu season was almost non-existent. So we hope that that's what happens here. But everybody should get their flu vaccine anyway. The question of, is this going to be seasonal? We really don't know. I mean, we just do not know. It's going to be how effective the vaccine is, and does it mutate from season to season the way influenza does to give you just enough that you need to be revaccinated. So we have to be humble and admit that we don't know whether we're going to be able to eliminate it in a one-shot basis so that it's around maybe for 1 or 2 years and then it's gone, or whether we have to worry about this every year and essentially vaccinate people every year. The one thing that's for sure is that common cold coronaviruses keep coming back every year, and people get reinfected with the same virus that they were infected with before. So hopefully this coronavirus doesn't act that way. But if it does, we're going to have to be prepared that we need to address it on a seasonal basis.
And Daniel wonders, how has your experience with disease like Ebola and SARS helped you with managing the current pandemic?
Well, I mean, in some respects it's helped, but in some respects it's gone beyond that, because it has a characteristic that neither of those other viruses have. And the characteristic is that it's spectacularly capable of spreading from person to person. Whereas SARS, as much as it was a pandemic, we were able to control it purely with public health measures until it disappeared.
So I have a question from Amy, and probably this is the last one given your time and the time of the lecture, is how long after a vaccine is administered will be safe to open without the risk of another spike in the pandemic?
Yeah, great question. It's going to be a projection, Facundo. We don't know exactly how long that will be. We're projecting that if vaccines are proven to be effective in November, December, January, and we have doses available and we vaccinate people, a lot of people are going to be reluctant to get vaccinated. It's going to depend upon how effective the vaccine is and how many people are willing to accept getting vaccinated. If we have a lot of people get vaccinated and the vaccine is very effective, I think by the end of 2021, that we would probably be able to begin to approach some degree of normality.
So, Tony, thank you so much for your time, for a wonderful lecture, and a special thanks on my behalf, and I'm sure of the rest of the audience, for all the efforts that you are doing to guiding us through this pandemic. I mean, we are incredibly appreciative of your personal efforts and devotion to this. And again, thank you so much for an inspirational talk.
Thank you, Facundo, and thank you for giving me the opportunity to be part of this course. It's a lot of fun. Thank you. Take care of yourself. Stay safe, everybody.